Hi, everyone. I'm back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Evelyn from Nashville Fertility Center, and I'm joined by my electrifying, enjoyable, and entertaining co host, Dr. Carrie Bedient from the Fertility Center of Las Vegas,
Hello.
and Dr. Susan Hudson from Texas Fertility Center. How are you
Hello,
guys
everyone.
doing?
We are good.
Are you getting in the Christmassy holiday spirit?
Getting there.
They're
I know
working on it.
I've got a lot left to do, I think. So I just found out something. Well, didn't just find it out, but I found out something kind of interesting. So most people are pretty familiar with the Elf on the Shelf. I think he's been around for at least 20 plus years, I think. So I just found out last year because I visited the Tennessee governor's mansion. I was invited to do that. I
Ooh.
mean, wasn't just me, it was a lot of people. But anyway, we went and one room was completely decorated with Elf on the Shelf like everywhere. And I'm like, okay, this is kind of interesting. We'll come to find out the woman who invented or came up with the concept of Elf on the Shelf is from Tennessee.
Oh,
So
that's
that's why
cool.
the governor's mansion was all decorated with it. Do you guys use the Elf on the Shelf? Have you ever
No,
used that in your house?
I never used Elf on the Shelf. My kids, when they were little, they had it at elementary school and they begged and pleaded every year to do it. But quite honestly, like there are so many other things that are like my priority, and moving that damn little elf every night and coming up with something witty to do is like that is not in like my gift. That is not my
That's
cup of
not your
tea.
wheelhouse, in your
That is
wheelhouse.
not my wheelhouse. And so I appreciate other people who, I mean, I love watching on social media these like Elf on the Shelf like ideas, and they crack me up and they are fantastic for anyone who has the energy and interest in doing it. But it wasn't my thing. I think
Well,
they're cute. I think it's a great idea.
I
But
found when I was doing this that the messier we got with it, the more fun everybody had, but which was harder to clean up. But I actually just this year heard about people who like for fundraising are doing like Elf on the Shelf kits. Have you heard of this? Carrie, have you heard of this?
No.
So it's where they basically come up for you like all the days that the elf is going to be out, like what you do each day, and it has
like
stuff
it's
in
a
the kit.
pre, it's almost like an
Yeah.
advent calendar for Elf on the
Yes.
For
Shelf.
the elf.
Yeah. And it has all the stuff that you need to like do whatever that
Oh,
particular
that would
thing
be
is. I'm
so
like, that is
helpful. See,
genius.
that
That is,
takes out all the like creative things I don't have.
yeah, I think that's genius. So yeah, just one more thing to deal with over the holidays, right?
No, good
I'm
stuff.
far too inappropriate to do Elf on the Shelf because if I did it, I would probably number one, I would be the one who woke up in a panic at 3 a.m. going, "Oh my God, I have to move the fucking elf."
Yeah.
And I
I've done that before.
guarantee that is 100% the language that would be going through my brain at 3 a.m. And number two, I would do the things like,
It would be like
oh,
pooping marshmallows and
yes,
little
yes,
chocolate kisses.
uh-huh. And there might be a murder scene with strawberry jam
Yeah,
or
that probably wouldn't be a good idea.
yeah, like doing lines of cocaine with powdered sugar or
Now I've never heard of that one. Yeah, that'd be a little inappropriate, I think,
yeah,
probably.
yeah, like you can't let me loose on something like
Carrie's
that.
more the idea for the adult version of Elf
That's
on
what
the
I was gonna
Shelf.
say, Carrie. That you just
100%.
have come up with the concept for the adult version of Elf on the Shelf. It's genius. It's the
It is
same
really
concept,
good.
just for different
Maybe
different
I do
people.
that for my office.
Oh,
Like
that would
maybe
be
I do it for all
funny.
of my staff members and do it, of course, clearly hidden, not where any patient coming in could see it. But
Yes,
maybe
That's
if
a
I
great
can
idea.
get it
Maybe if you do
together.
it, put it on
that would
Instagram.
be
We
funny.
want to see what you do.
Yeah. Oh, because our office actually we have a male elf and a female elf. And I actually think that we have some duplicates because we have a lot of, LGBTQIA patients as well. And so I think we have some duplicates in there. Also, I have a dog at home. That's not going to end well. Like the elf dog.
You have an elf dog?
Yeah, because the elves are creepy to me. So when I was going to buy them, I didn't actually buy the stupid elf because I didn't want it living in my house because it kind of creeps me out. It's got a Big Brother-esque look to it. Their eyes are shifty. They're very
Yeah,
odd. They
they
have
are a
these
little
bright
bit
little
weird
blue
looking.
eyes that are just watching Big Brother.
Yeah.
Yeah, no, no, not in my house. Susan is gonna fall off her chair laughing right now.
Oh my goodness, that's so funny.
All right. Well, what question do we have today, Susan?
All right, we'll do a couple. The first one is, hi docs. It's been a pleasure listening to your podcast, and thank you.
Oh.
I'm 37 with secondary infertility and migraines with aura. Workup revealed TSH 2.99, AMH 0.7, TSH being treated. I have a 3-year-old. Her conception pregnancy was easy, delivered via C-section due to failure to descend. Had 2 miscarriages at 8 weeks in the past year at 37. RPL workup in progress. Plans for IVF in near future. I haven't found much information on risks of VTE with IVF protocols for women with migraine with aura. I did hear you saying that migraines with aura is a relative contraindication for IVF. Why? I will be undergoing Lupron Follistim IVF protocol with the HCG trigger in the near future, but I'm freaking about the risk of VTE or venous thromboembolism. Any comments or suggestions? Thank you. I don't ever discourage somebody from doing IVF because they have migraine with aura. I mean, I think the data is really related to oral contraceptive pills. And yes, that means you're going to have with oral contraceptive pills, you have a little bit higher estrogen concentration, a really higher concentration of progesterone. But, I think it's one of those things we're all aware about, but we're all aware really in anyone, whether they have migraine with aura or not. So I think it's good to be aware of signs and symptoms, but it's nothing I would lose sleep over. What do you think?
Yeah, I would go the same way because when you think about the list of things that when any of us have a patient who gets pregnant, whether it's through IVF or not, or what have you, there are things that pop up that automatically make us worry. So, for example, for someone who's actually had a DVT or PE, those big blood clots that get stuck in problematic places, for someone who actually has multiple copies, not just one, but multiple copies of some of these really problematic blood clotting genes, things like that, there's some indications where as soon as we know you're pregnant or we are giving you hormones to go through whatever fertility treatment, we will automatically put you on blood thinners. And we won't even let you get close to any of those hormones without doing something preventative. When you're talking about migraine with aura, it's just, all right, let's be aware, but it so rarely, knock on wood, turns into something big and ugly and dramatic that it's actually riskier to just default put you on those blood thinning medications than it is to just say, okay, let's watch out. Now, I do think it's helpful to know, yeah, if all of a sudden one leg is super swollen and painful and the other one's not, or you feel like you're having a really hard time catching your breath, don't blow it off. But at the same point, you should probably tell that to just about everybody of if you can't breathe, that's a problem, and you should probably go get that checked out. And so,
We joke about that, but you'd be
yeah.
amazed at how many times we've had patients who
Oh,
have had trouble
yeah.
breathing, not necessarily because of this, but anything. And they wait to tell us if you cannot oxygenate, like that's a problem. So get medical attention immediately.
Yeah, like that's the oxygen is not doesn't
Optional.
hurt. Get a
It's
little
not
more in.
optional.
It's not optional. You have to have it. And I always joke with my patients, especially when I'm doing something that is uncomfortable, like, okay, we encourage breathing here. And I say that tongue in cheek, but it's not actually tongue in cheek. We do, in fact, encourage breathing here.
Yeah, and as a side note on that, one time I had a patient who was one of the rare people that did have one of those and presented, and I said, well, does it hurt when you, or I said, when you breathe, do you have trouble taking a breath? And she goes, well, no, it just hurts. And I go, well, when does it hurt? And she goes, well, only when I breathe, it hurts. So the other symptom of DVT is if you breathe and it hurts, let us know about that. That's really scary. And the one thing I would just add to what you guys said too is I always like to get input from people who know a lot more about migraine headaches with aura than I do. So I think it's probably a good idea for you to see a neurologist and just have them weigh in on it and just tell them what you're doing. And a lot of times I'll say, have your doctor send me a letter and let me know if there's anything we need to change or do differently that could impact your care in a positive way. And so I think it's always good to kind of get their feedback too.
All right, let's do one more. Hi there. I'm a 25-year-old female from Manitoba, Canada. So hi from from the US. Thank you for listening to us. I have a 1.5-year-old daughter. My husband and I are 27, have been trying to get pregnant since May. I know that's not a lot of time, but in the last 7 months, I've been diagnosed with endometriosis. I've had ovarian cysts, 2 miscarriages, kidney stones, and a uterine polyp. My
Oh,
doctor
wow.
at the ER during my first miscarriage said I was just having an early period or a miscarriage, but didn't do anything beyond that. I have always struggled with bad, painful periods with heavy bleeding and lots of pain almost daily between periods. Is there anything you could recommend to me? I feel like my OB isn't taking me seriously.
I mean, I think if you're having pain and painful periods, that's a reason in and of itself that somebody needs to laparoscope you and see if you have endometriosis. I mean, to me, that's a separate issue than fertility, although they're, closely interrelated. But, 10, 15 years ago, we used to laparoscope everybody and look for endometriosis. And now we really reserve that for people that we really think have cyst of endometriosis, have pain from endometriosis, have pain from periods, and you're in that category. So I definitely think you need to have laparoscopy. Somebody needs to make a diagnosis, and hopefully, if your cysts are endometriosis and they get rid of them, in my experience, most people feel a lot better and they don't have nearly the same amount of cramping that they had before. Now, endometriosis can come back, and so what that means is right after you have that surgery, if they find it and they treat it, then you need to start trying to get pregnant really quickly with whatever process you're going to do that, because ultimately endometriosis can come back really quickly, particularly if it's in your ovaries. I've seen it come back in 6 months to certainly in 12 months potentially. So you really want to try and use that to your advantage, because right after you have the surgery is when you're the most fertile.
Pelvic pain is a really complex thing to work through. And so when we're thinking about it strictly in the gynecologic sense, endometriosis is always at the top of the list. Sometimes ovarian cysts can be problematic, even if they're not endometriomas. Sometimes PCOS can cause problems, more from having really, really heavy bleeding, more so than pain. But there's like a set of diagnoses that we see all the time. Adenomyosis is high on that list. And so those are all things that we can work with and work through. Sometimes some preventative medication protocols, even just starting ibuprofen a day or two before your period starts to prevent those nasty little prostaglandins that cause pain from even forming. Those are all things that we can do. But you also have to remember there's your bladder that's right there and your bowels that are right there. And both of those things are known to be problem children at times. And so interstitial cystitis of the bladder, chronic urinary tract infections, any number of bowel diseases, all of those things can apply. And so while you definitely need a gynecologist to run through our list of things, they very well may say, look, you need to go talk to a urologist, you need to go talk to a gastroenterologist, because all of those things are right crammed into a very small space together. One of them can easily irritate the other ones. It's very hard to distinguish, this is my uterus, this is my bladder, this is my bowel, because they are so close together, and one organ that's acting up can make the other ones actually hurt. And even though it's not that problem, it originates somewhere else. Like, you really have to kind of go through it all very methodically and say, okay, where are the potential problems, and get a cystoscope, get a colonoscopy, get all those things. Now, not every patient with pelvic pain needs all of that, but some of them do, because sometimes you really do have to dig and you need multiple specialties working together to figure out, all right, where is this problem and how do we best get you through it? Pain management clinics are also really helpful, because there's sometimes, endometriosis is known for this. Some of the inflammatory bowel diseases are known for this, where the pain is chronic no matter what we do. And so if you have a pain medicine clinic that they specialize in all of the medications that help people manage pain, not just physically, but also psychologically as well. Like, this is very much an interdisciplinary sport to get somebody through this to a point where they're comfortable.
So I have kind of 2 comments on both of your comments. So Carrie, one additional thing I would say is going to see a physical therapist
Yep.
who specializes in pelvic pain, because as Carrie mentioned, a lot of these organs have cross innervation. So if you're having pain caused from one or the other organs, it can mess up their next door neighbors. Okay.
And the muscles too. We didn't mention that. The muscles are problematic.
Yeah.
Yes. So that is something. I would say, just because you have pain I would not take you quickly. I mean, immediately for laparoscopy. I would probably try some medical approaches of trying to control your pain and getting that under control, and things that might also give us some advantage when we're going into fertility treatment, potentially using medications like Lupron or Orlissa for a couple of months to get any endometriosis calmed down. I do think, though, potentially having a hysteroscopy, looking inside the uterus to see if there's any residual products of conception or polyps. If you're still having heavy bleeding, I think it's probably worth a look. We want to be proactive in getting you well, but also realize that if you do have endometriosis, one of the best ways to squelch it is for us to get you pregnant. And so I understand you're in Canada, so it's a little bit of a different medical system.
Harder to have laparoscopy up there, I know for sure. Yeah.
That you're having to navigate, but you may also have long waits for surgical intervention as well. So those are
Well, and I think that's where you sort of have to decide what's your priority right now. If this is chronic pain that's been going on, and I don't remember if you said even before you had your first child, if this has been going on for a long time, I would vote to do laparoscopy. That would be my vote, because I just think you really kind of need to make the diagnosis and know if it's there. I think you'd mentioned ovarian cyst, and there's all kinds of cysts, and actually we just did an episode recently on that. There can be normal cysts and there can be abnormal cysts, and endometriomas have a characteristic appearance. And granted, you can't make the diagnosis looking with ultrasound, but we look at them a lot and we're pretty good at saying, yeah, that's probably an endometrioma. So if you have this history and you've had endometriomas, it looks like endometriomas, I would say I do laparoscopy. I would focus on that first, because ultimately if you get it knocked out, then a month or two later you can start with treatment. So it's just one of those things. It's talk to your doctor and see what they say and see what the imaging looks like and make a decision based on that.
There's some different ways to manage this.
Yeah.
So today we're going to talk about donor egg. So, Carrie, when would somebody choose to do donor egg? At what point would you say, you probably need to move to donor egg?
So I have two general approaches to that. One is the physiologically, we just don't have much of a choice. And that is oftentimes for patients who are in their late 40s, mid 40s, sometimes in their earlier 40s. So women who have gone through premature ovarian insufficiency, where they have really menopausal levels of hormones and egg numbers, and regardless of their age. So those are people where we tend to move pretty quickly to egg donation, because physiologically the likelihood of success is so far under 1% that the realistic likely chance of us getting to one of their own eggs to create a baby is so small as to be considered futile. And and our goal is not to make you suffer. Our goal is not to give up on you easily either, but we want to make sure that we're giving you reasonable advice as we're going through. So that's one group where physiologically it just ain't going to happen. They don't have ovaries, they don't work, they're aged out because of normal aging. And so when we tell somebody, hey, we need to think about egg donation, it's not because we are giving up on you in any way, shape, or form, because I guarantee you we've got a longer appetite for going on retrieval after retrieval after retrieval than you do, because we are not the ones paying for it. And we will keep manipulating cycles in hopes that you are going to be the one. And so there's that set of patients. Then there's the set of patients where there's really a very low chance. And this is a harder group, I feel like, because when you have somebody who comes in who's, let's say, a male couple or a single male, or a woman who's had chemotherapy or doesn't have ovaries, like those are easy decisions to go to donor eggs because they don't have any other option. It's when you have patients where they have eggs, but the numbers are really low. Their hormones are just far enough in the okay region to not be clearly absolutely terrible. These are where the percentages are low, and we're kind of balancing, okay, if we do this, what's the success rate? Or we have done this and we've done it a couple of times and it hasn't worked. So maybe now you're hitting the point where you're over it and you just want to do whatever you need to do to get a baby. And the genetics are less important to you because you want a family, not necessarily, your own 50% of your genetic material in an egg. And so those are the ones that take a little bit longer, I feel like. The ones that are, the same-sex male couples, the very clearly over the age of 45, all of those are really easy. It's the other ones that take a little bit more finesse of, okay, you're 27, but you had 8 rounds of chemotherapy and you have eggs, but this is not
They're
going
probably
well.
not
We've
good.
done it 3 times and we can't
Yeah.
get anything. So those are my 2 general groups of how I think about people who need donor eggs. The obvious, you can see it a mile away, and then the other ones where it takes some work to get there.
So Susan, if someone makes a decision they want to do that, where do they get the eggs from?
So there's a couple of different ways to do this. So most people in the United States are going to use some anonymous or semi-anonymous source of eggs, and we'll get into that, versus using a known donor. So a known donor is where you have a sister or friend or acquaintance that you actually know that is wanting to be able to provide eggs for you to be able to grow your family. The other option is to get eggs from either an egg bank where eggs have already been retrieved through the IVF process, or through an egg donor pool. So women who would like to be selected as egg donors have been initially screened, and you can choose from those individuals. So those are kind of the 2 broad categories. Like I said, most people in the US, I think, still use anonymous or some sort of anonymity, maybe with eventual disclosure. But in a handful of cases, known donor egg can be a beautiful thing as well.
So Susan, tell us, what's the fly in the ointment now with known versus unknown or versus anonymous donors?
So
What's the issue now that we have Ancestry.com and 23andMe?
right. So the reality is, in today's day and age, nobody is truly anonymous. With facial recognition technology and all of the genetics, if you are choosing to use a donor, or a donor is choosing to be a donor, there is a very real likelihood that there is going to be a connection made at some point in the lifetime. And so,
A connection. What do you mean by connection?
like, people are going to be able to figure out who is who, whether
Right.
you
Or,
planned on that
and
happening or not.
and
And
even
so,
brothers and sisters and siblings and things like that, potentially too. Yeah.
exactly. And so that's one reason why, whether you're going through known or anonymous donation, that our national society, the American Society of Reproductive Medicine, recommends counseling to talk with somebody who has really been trained in what we call third-party reproduction. So things like donor eggs, donor sperm, gestational carriers, those types of things, to really talk about those things like disclosure, non-disclosure. How do you tell? Who do you tell? When do you tell? Because I think there's very good data, especially from what we've learned through the adoption world, that going and being able to make the donor process as part of a child's story is much better psychologically for that child and their family than, when they're, 25 years old and they get a phone call or an email from somebody saying, "Hey, I think I might be your half sister."
Yeah.
That's not a good way to find out about things. And so, it's kind of a hard thing, I think, when people are coming to the decision of egg donor, because they want things to be private, and they're wanting it just to be their thing. But I think it is important for those close around you to know.
So, Carrie, when somebody makes the decision to do it, there's a lot of steps involved. So, tell me about what the donor has to go through when she decides, yep, I'm going to actually donate my eggs to someone.
So processes are a little bit different from place to place, clinic to clinic, but
Yeah.
first thing that she has to do is she has to find find the clinic to work with that will help her do this, because of course you can't do it by yourself. And so typically what happens is she submits a really long application. I know ours, I go through all of ours, and it's a solid minimum of 20 pages, and often,
yeah, I say 20 or 25 for us.
yeah. And those applications are going through not just the demographics and giving photos and all those things, but it's also everything about your medical history that you can possibly think of, not just for you, but for every family member that you have a blood relationship to, because we want to know what runs in the family, what doesn't. And when we're looking at those, so most clinics are going to take donors between the age of about 21 and I want to say 34 is the upper ASRM limit, but a lot of clinics will cut it off somewhere in the 30, 31, 32, somewhere there.
Yeah.
And so by default, they don't necessarily have the same family history that someone who's 50 years old is going to have, because when you're 50, you've had 50 years to accumulate insults to your health and your family's health. When you're 25, you just haven't had that same amount of time. So there are going to be some people who have very little to share, and there are going to be others who have a whole lot. And that's also related to the interconnectedness of the family. Do they believe in doctors? Do they go to doctors or not? I hear about this a lot from male family members of, yeah, I think dad's fine, but he hasn't seen a doctor in 45 years. So they go through this really long questionnaire, and usually they're brought in for an ultrasound as long as their questionnaire looks reasonable. The ultrasound is checking to make sure that they've got a good egg count and that they're a reasonable candidate for a donor. At that point, some places will go through and do 100% of the screening right away. Others of them will wait for that donor to be chosen. Regardless, once they know that they need to go through the rest of their screening, what they're going to do is they're going to come in for a full medical evaluation. We're going to go through their medical history. We're going to do a physical exam. We are going to do vaginal pelvic ultrasounds and get an egg count. We are going to send them to a genetic counselor. We are going to send them to a psychologist. We are going to draw an ungodly vampire amount of blood, because we're looking at infections, we're looking at general health, think like diabetes and thyroid. We're looking at genetic carrier screening for her. We're looking at a karyotype for her. We're really pretty nosy. And so we get,
and it's not just us though, it's the FDA, right? The FDA is the one that says we want to really make sure that everybody's healthy going into this process and that we have a healthy baby. So a lot of it, sometimes patients will go, well, why does my partner have to be tested if I'm donating the eggs? It's, well, we want him to be healthy too if you guys are having sex. And so the FDA gets involved, and some of it is required testing that we have to do. A lot of it is.
Yeah.
And we want you to be healthy too.
The FDA specific testing there is a very long questionnaire that's designed to be a risk assessment questionnaire. There is a physical exam that is done in close proximity to those eggs coming out. And then there is a special set of blood work. So depending on the setup, a lot of us will send off that basic blood work first to just a general lab, just to make sure there's no problems, because once we send it to the FDA lab, that is a definitive set in stone result. And so that lab is held to a higher standard. And so what we're looking for is making sure that everything is absolutely as squeaky clean as possible, because these eggs it's not like you're working with an intimate partner to make a baby. This is a completely non-intimate partner, oftentimes someone you've never met before. And so we have to make sure that all of the infection concerns are met, and that there is just no doubt about it that this is an okay thing to do.
So one
Susan,
thing I'm going
Go
to
ahead.
interrupt just real quick. So one thing to understand, from the time somebody signs up and puts in their name in whatever website they go to or whatever, to actually being selected as a donor, most donors are in the 1% to 5% of people who actually applied. So there's a lot of filtration that goes into the system. We want people who are going to be honest, reliable, give us the full story, and be good donors, because we know that you have a lot of hopes and dreams hanging on this.
And there are people, I was going to say, there are people who, as they're getting through, even if they look like phenomenal candidates, I can think of one donor who, she came in and everything looked fantastic. We were all set. After she left, we opened up one of the cabinets, and she had taken all of the condom covers for the ultrasounds and turned them into balloons and tied them off and loaded up a cabinet with condom balloons.
Oh my
And
goodness.
so even though she was a fantastic candidate medically, she was out. And so they have to pass the smell test too, because
Yeah, if there's anything to make you think that something's not right, then we don't use them.
If there's a thought, it might not be a good idea. They're not included in the pool.
exactly.
Absolutely. All right, so on to my question now. So, what
Sorry.
kind of screening do we do for the intended parents?
Right. So the intended parents, a lot of times, if you've already been through some fertility testing, most of your things probably have been done. For the woman who's going to be carrying the pregnancy, we of course want to make sure your thyroid looks good. We want to do a saline ultrasound and trial embryo transfer. I like to have an HSG to make sure you don't have any fallopian tubes that are going to decrease our chances. We of course want to make sure you don't have any anemia that could negatively affect your pregnancy. And those are kind of the big things. Okay. Every clinic's going to have their various and sundry constellation of symptoms. For a male partner, we would want to make sure that he has had carrier screening, because if the egg donor is a carrier for something, we want to make sure the male partner is not also a carrier and vice versa. We will do testing on sperm, because we don't want to wait till the day of an egg thaw or egg retrieval to find out if we have enough sperm and good enough quality sperm to actually inseminate the eggs. And we do infectious disease labs on the intended parents as well.
What kind of testing do we do for emotional health and to make sure that this is a good fit for everybody, Carrie?
So we send to a psychologist, typically someone who's very well versed in
Mhm.
third-party reproduction. And so they're going to do, certainly on the donor, an evaluation, usually on the intended parents. They will also do an evaluation. And on the donor, they'll also do some psychological testing, extensive sets of questions that have been validated, and making sure that there's nothing that we need to be concerned about. And it's not a judgmental thing one way or the other. Like, yeah, if you've got a history of anxiety or depression, yes, we want to know about it, but we want to know that from your medical history standpoint. It's more making sure that there's nothing going on that means you're being coerced into this, that there's nothing going on in your background that maybe needs to be dealt with first. Sometimes there's identity issues, sometimes there's abuse issues, sometimes there's any number of things that pop up. And it's mostly to preserve the health and the integrity of what we're doing here. Because if someone shouldn't be doing this, or they need to wait, which is oftentimes just what it is, then that's fine. We're happy to take the time and make sure that what needs to be dealt with is dealt with, because this is not just that person. This is the person on the other end of the line, whether that is a donor or an intended parent, and it's the child down the line. And so we want to make sure that we're just being thorough all the way through the process, which is part of the reason why when someone says, okay, I want to be a donor, it takes several months for them to be completely through all the testing and for everyone to say, yeah, okay, this is an okay decision.
I'd like to say that when we're doing the psychological component for donors, like there is a judgmental call we're making there. Okay. Of do we think that this person is doing this for the right reasons? They're not being coerced. There's nothing, they're not doing it to get drug money or anything crazy like this, And so, but when we're doing this for intended parents, it's really to make sure, one, you're in a good state of mind to be moving forward with this. This isn't something you have rushed into, and to give you information. So a very non-judgmental versus, I would say, a more judgmental, because we're trying to protect on all sides.
Mm-hmm.
So once a couple makes the decision, okay, we want to do this, we're ready to get going, we've selected our donor, then kind of
Let's
what's the
back
next?
up before selecting donor. Let's talk about fresh versus frozen.
Okay. I don't think all centers have that capability though. Like I know we don't really have that capability, but some centers do. So for the centers that do, tell us what you do.
Yeah. So for the centers that have both fresh and frozen options, so what that means is, so some people use frozen eggs, cryopreserved eggs. So women who have already been through the entire screening process, have already gone through egg retrievals. these eggs have been broken up into what we call lots, and those lots usually roam to 6+ eggs. Oftentimes you can buy as many as you want within, whatever's available in that cohort, to be eventually used. Now, the other option is some centers have a fresh donor pool. So these are ladies who have gone through initial screening and are waiting to be selected. Now, in either of these, you get to know pretty much all the same things: height, weight, hair color, ethnic background, family history, medical history, education, interests. There are usually childhood pictures. Depending on the organization, you may get adult pictures, but most are childhood pictures and those types of things. So most of the things you would really want to know. On the fresh donor, that person is then selected. They go through final screening because, as Carrie mentioned, that has to be done within a certain time period. That woman then goes through an egg retrieval. That those fresh eggs are then inseminated with the sperm of choice, and the embryos are created, grown out, usually to the day 5, 6, or 7 stage. In either case, you can do PGT or chromosome testing on the embryos, and then embryo transfer can either be a fresh or frozen embryo process, depending on how your clinic and your lab work most efficiently.
So, Carrie, how many eggs should someone choose?
So all of that is very dependent on what the clinic setup is, whether you're using fresh versus frozen, how many kids you want, what the quality of the sperm is, and
Well,
how.
give us a parameter. What would be the least amount and maybe the most amount that you would say?
So usually if you're choosing a number of eggs, you're dealing with frozen eggs, because when you're using a fresh donor, most of the time you're going to get all or a majority of those eggs. And there's some clinics where you just automatically get all of them. There are going to be others where they say, okay, you have the first 20, and then above and beyond that, those go to be frozen for future use, whatever it may be. So if you are buying frozen eggs, those lots are going to be predetermined. Oftentimes there's some cases where you can buy it by the egg, and so you may say, I really only want one kid and I want to make sure that I have no extra embryos. And so in those cases, you might have someone who buys relatively few eggs with the thought of, if I don't get a good embryo, I'm going to go back and I'm going to buy some more. And that has the advantage of having very few embryos ultimately, because you may only start with, let's say, 4 to 5 eggs. But it has the disadvantage of you're likely to have to pay much more because you're going to be going through the insemination and embryo culture process multiple times.
And the embryo costs can be substantial.
Yes, they can. And so when you're looking at someone who's just like, yeah, I want maybe 1 to 2 kids, a lot of times those will be somewhere between like 6 and 12. In terms of the number of eggs that you buy. For someone who knows that they want a large family, then
More the better.
The more the better, because the issue with eggs that are already frozen is that you are paying for the advantage and the convenience of all the work having been done, so that all you have to do is put in an order online, and it's going to go to your lab and they're going to finish off the last part of it with all of the 3-month lead up, 6-month lead up, whatever it is, already having been done. But frozen eggs are a little bit different than fresh eggs because they have already been through the freeze thaw process once before the insemination ever occurs. And so oftentimes they take an extra day to grow out to embryos, which that's not necessarily a problem in the grand scheme of things. Like, those embryos end up being just fine, but you kind of have to know it. There's a possibility that not every egg is going to thaw and survive or inseminate appropriately. And so some of these things you just don't know until you get there. And so the number of kids that you want is going to factor in, and the quality of the sperm that you're dealing with. It's going to be very different if you have to use extracted sperm versus a healthy ejaculated sample.
It generally takes a few more frozen eggs to create an embryo, but once you get to the embryo, it doesn't really matter. And I think a lot of frozen egg banks actually don't recommend surgically extracted sperm being used with frozen eggs.
Right.
So something to consider.
Yeah,
Yeah.
one thing about the eggs too that's always challenging is whether they're fresh or frozen. The bottom line is you never know how they're going to respond until you put the egg and the sperm together. And so, it's like Carrie said, I wouldn't pick anything less than 6 eggs, and more is always better, just because you just don't know. And so, but it also depends on how many children you want to have, et cetera.
Mm-hmm.
So Susan, how do we prepare the uterine cavity to receive an embryo from a donor egg and partner sperm?
Yeah, so I pretty much do frozen cycles. So for those of you who may do fresh cycles, I'm gonna let Carrie or Abby answer that because I hardly ever do fresh cycles nowadays. So frozen cycles are actually relatively easy. If you have regular menstrual periods, you give us a call with your period. Once we have embryos created, we start giving you some estrogen tablets. Usually we give them to you orally. Sometimes we have you take them vaginally. Sometimes people use gels, creams, other sources of estrogen injections. And you start those and you'll do those for about 2 weeks. And then you come back and you get a blood test. I usually test for estrogen and progesterone. And if your estrogen is where I like it to be and your progesterone is where I like it to be, and I'm a lot more forgiving on the estrogen than the progesterone. Um, and if everything looks good, I do an ultrasound. We want to look at the kind of configuration of the lining of the uterus as well as the thickness. Now, if you'll listen to one of our recent episodes, we talked all about endometrial thickness. So you have to take this a little bit with a grain of salt. But if we like everything, everything looks warm and fuzzy, then we'll have you start your progesterone. We generally are using injectable progesterone, and you start that about, we usually do embryo transfer on your 6th day of progesterone. And we do that. Of course, you need to be taking your prenatal vitamins and all that kind of good stuff. And then pregnancy test about 10 days later.
And one thing I think we kind of scooted over, I scooted over, was most of the time we genetically test these embryos
Mhm.
too. So we only transfer a genetically normal embryo. So Carrie, how many embryos would you recommend transferring in a patient like this?
One.
Would you ever
And
make an exception, even if somebody really wanted twins?
I mean, rules are made to think before you break them, but I try very hard to avoid transferring two. When you look at
Yeah.
the recommendations, the recommendation is to do, especially when it's a single, especially when it's an egg donor, especially when it's genetically tested, to do just one at a time. Because
Hmm.
now that fertility treatments, IVF in particular, tend to be much better in terms of effectiveness, the next big goal is how do we make it even safer? And so it used to be that we would, as my statistician says, shovel embryos in, where I remember, I remember putting in 5 embryos because that was recommended. Like I was not doing anything suspicious, shady, on the edge at all. Like that was a very clear,
They were untested probably, and they
they
weren't
were
very high
untested
quality, and
day 3 from a 43-year-old,
yeah,
like
likely to be abnormal.
likely to be abnormal. You just put them all in because that was the recommendation. And I used to have that set of recommendations like glued to the back of my phone so that I always just had it readily accessible. Now, because what we do is so much more effective, the goal is minimizing the problems from multiple pregnancies because twins are more likely to be born much earlier. The moms are more likely to have diabetes, high blood pressure, premature delivery, all of the complications that go with a multiple pregnancy. When the babies are born early, they have just oodles and oodles and scads of potential issues. And while everybody sees the twins that are cute and adorable and stellar in sports and music and super smart, you never see the ones that didn't make it.
Yeah.
Mhm.
And we
Part
have
of part of our job is to make sure you don't live through some of the things we've seen.
That's
yeah,
right. That's
yeah.
absolutely right.
And so, never say never, but it means that you are very intentionally not taking your doctor's advice when you want to transfer to. And a lot of times we hear, well, it's going to be more cheaper or it's going to be less expensive. It's going to be cheaper. No, it's not. Those
There's
hospitals
actually
are
studies. There have
phenomenal.
been real studies that show that having children sequentially is exponentially less expensive than having multiples.
Mhm.
Yeah.
And we want to make sure that when you send us those holiday pictures at the end of the year, that there is not a tracheostomy tube, that there's no IVs in there, that those kids are up and walking when they should be. all of those things. Like we want to see you happy because this is not about a positive pregnancy test. This is all about the baby in your arms and the condition of everybody at the end of the road.
So, Susan, if somebody's too old to have, or say their eggs are too old and we don't feel like they can get pregnant with their eggs, is there a problem with the rest of them? Like, are they going to have a problem with their uterus carrying the pregnancy?
So generally the uterus doesn't age. Okay. Now, an important thing to know is though the uterus doesn't age, that doesn't mean you're not at increased risk of pregnancy complications. Okay.
Mm-hmm.
So anyone who's over the age of 35 is at an increased risk of things like diabetes in pregnancy, preeclampsia or high blood pressure issues in pregnancy, preterm delivery, increased risk of C-section, and increased risk of complications from all of those things, which sometimes the complications can be very significant. Now, these are all rare, okay? But they are reasons why, especially if you are in your mid or later 40s, we'll often recommend you to visit with an MFM or maternal fetal medicine or high risk OB doctor because you'll probably be followed by one of those people. MFMs generally don't deliver babies, kind of like fertility doctors, but they follow you along with your regular OB to give you another set of eyes and make sure that all our I's are dotted and T's are crossed and you and baby are tracking along the way that you should. So it is very important to make sure you're in the best physical condition you can be in. So if you already have issues with high blood pressure, increased blood sugar levels, pre-diabetes, any of those things, this is the time to like buckle down and get yourself as healthy as you can.
And Carrie, one very important thing that we forgot to mention is the legal aspect of this. So tell us a little bit about what you need to think about if you're going to do this.
So there's a couple things to consider. Probably the biggest is making sure that the contracts are appropriately completed. And this is sometimes it'll be done by your clinic, sometimes they'll send you to an outside lawyer, kind of depends on the circumstances. Anonymous donations are sometimes a little bit more streamlined than if you're using a known donor. But the
Mhm.
upshot of all of it is that there needs to be a very clear contract about whose baby this is and who gets to make decisions at the end of the day. And what that typically means is that once those eggs are out, they belong to the intended parents to make whatever decisions they want to make about creating the embryos, about disposing of them, about the transfer of them, about donation and how whatever their final disposition is if they don't get transferred, all of those things. Now, it's a contract, so any contract can be worked any way you want, but there's some logistical components as a part of that. And so typically kind of the standard is that once those eggs are out, they belong to the intended parents to care for. So all the financial burden is on the intended parents, as well as to make decisions about. And those contracts are super important, and nobody's going to do a thing until they are very clearly in place and ready to go.
And interestingly enough, in the state of Tennessee, I don't know, and it's state to state, but when you deliver that baby, you're listed as the mom on the birth certificate. It doesn't matter that it's somebody else's eggs, and I'm
Mhm.
sure it's
Mhm.
similar in other states as well. But there are different state laws for different reproductive things that we do. So,
On
so I,
on that note, I do want to say that this has only happened to me once, but if you do get pregnant using donor eggs, the physician, the OB-GYN that's taking care of you during your pregnancy really needs to know this. Okay.
yes, that's a great point.
Because like I said, this has only happened to me once in my career, and it was a long, long time ago where the couple refused to have that information
I,
shared.
I've
But
had that
realize
happen before twice.
yeah,
Yeah.
but realize that when they're doing testing on your baby in the second trimester or even in the first trimester, all of the algorithms are based on the age of the person who produced the egg, not necessarily you. And so all these things are very important for them to understand kind of your full situation and what are your risks during pregnancy and risks to baby for birth defects and chromosomal abnormalities and things like that. So I highly encourage you to, I know, again, this is very private information, but you do need to share it with your care team when you transition away from your reproductive endocrinologist to whoever is going to be caring for you during your pregnancy.
All right. Well, I think we have covered a lot of ground here. Any other things that we need to cover that you guys can think about that we didn't hit?
Not today. Lots of good things for another episode, though.
All right. So to our audience, thanks for listening and tune in next week for more. Be sure to subscribe and leave a review in iTunes. We'd love to hear from you. You can follow us on Instagram or Facebook. So hop on and leave us a like or a comment.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment. So don't hold back. We love episode ideas. So let us know what you're thinking and want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right. We'll see you soon. Bye.
Bye.
Bye.